Hello, I am Dr. Jingu Kim. I'm with Yonsei 9 Dental Office. In this master course today, I'm going to talk about the bone materials used for maxillary sinus floor augmentation. I hear some say using bone graft material in sinus is good and some say it's not. Today, I'm going to briefly talk about how much and what kind of graft material should be used. Usually, many people use allograft. It is one of the most widely used bone graft materials, and I like it too. But it depends on person to person. It's a personal preference. Some say they only use by us in the sinus. So today we are going to look at the characteristics of each material. There are many different types, and which one should I use? Let's look at the types of bone graft materials. There are so many varieties. This is a very old consensus report on sinus graft. The very first consensus report, you can see what concept people had in the mid-1990s. Here, alloplast. 5-year success rate is 98%. Allograft, success rate is 85%. Particulate autograft, 91%. That was the conclusion. At the time, there are many other papers. Review papers would be more important than which bone materials I prefer to use. According to the review journal, in 1998, the success rate was only 90% if you use autogenous bone. HA and autogenous bone, 94%, DFDB and HA. Mixture of xenograft and allograft, 98%, and HA alone, the rate is lower. According to the paper published in 2004, autogenous bone, 87%. If it is mixed with xenograft, 94%. And bone substitutes show the higher success rate. Now, we use a lot of allograft, xenograft, and synthetic bone, and autogenous bone is not widely used because it is considered to have more demerits over merits in the maxillary sinus. If you look at here, autogenous bone first. Autogenous bone is considered as the gold standard, and it has many living cells, a lot of advantages because it forms bone pretty well and there's hardly any side effects. But autogenous bone should be harvested intraorally or extraorally from iliac bone, tibial or rib bones, and we don't do it anymore to place an implant. We need to harvest the bone intraorally from tuberosity or tori or bone in the edentulous area. Most often we take bone from ramus, but the amount we can get from them is not sufficient to augment sinus floor. Internal donor sites or other areas may get injured, so we don't take bone intraorally that much these days. We take bone from ramus after extracting a wisdom tooth, or we take bone from the center of chin using an instrument like autobone collector. However, these days I do not use autogenous bone. That is the conclusion. Autogenous bone has limitations. The biggest problem is the donor site morbidity. That's why it is not widely used these days. Most widely used bone, allogenic bone. There are not many countries where this can be used. It is allowed in Korea and the US, but it is not in Europe. In Korea and in the US, allogenic bone takes up 50% of the market share. What is important when selecting the bone, you need to look at the selection criteria. Tissue bank and the donor condition should be considered. First, the tissue bank. When it comes to allogenic bone, we need to look into tissue bank. Bone is harvested from a donor and is processed into finished product or semi-finished products. Tissue banks provide bone materials to bone material manufacturers. Is the tissue bank reliable? That is very important. Allogenic bone is used by orthopedic department quite a lot. And this is the paper on bacterial contamination of allografts. Who is the major donor and primary tissue bank used? Where is the country the tissue bank is established? These things need to be identified. Second, donor condition. If someone is too old or if the person had diseases. Bone from young donor is much better. Bone is usually taken from the condyle of femur. Another important thing is the cortical bone versus cancellous bone ratio. If you include a lot of cortical bone in the material, bone formation capability of the bone material will be reduced, and if you have a lot of cancellous bone, that's good. However, the amount we can harvest is not so much. Therefore, manufacturers mix cortical bone. If there's too much cortical bone, then it's not very good. Next, cortical bone versus cancellous bone ratio. The ratio differs from manufacturer to manufacturer and also differs from product to product. Manufacturing process, antigen, can be from donor. So the material is processed to reduce various immunoresponses. Example, gamma ray irradiation, freezing, drying, and demineralization. Not all bone materials go through these processes. Most of them have been processed with freezing and drying, but not demineralization always. And demineralization can make an important difference in the result. Next, the powder, chips. Depending on size of particles, a powder is 0.2 to 1 millimeter. Chips are bigger. It's a personal preference, your choice. In the maxillary sinus, syringe type is more favorable. I prefer syringe type very much. Let's look at a clinical case. The dotted line indicates residual bone and sinus floor. In this patient, an implant will be placed in the area where residual root remains. At number 15, residual bone is sufficient. At number 17, insufficient. So lateral approach should be used, and the crestal approach cannot be done. And this is an extraction case, so lateral approach will be done. A window is made. Membrane was checked and detached, and the graft material was put in. In this case, I used allograft, short os, repositioning, and minor GBR around the molar, which has many roots. And it was finished like this. You can see a lot of bone graft material. After surgery, soft tissue was healed properly. Post-op 3 months, impression was taken and the prosthesis was fabricated and delivered. Screw holes and the shape's okay, and it was finished pretty well. Post-op, and it was voluminous graft, but it was resorbed gradually, and the post-op 3 years, bone graft material has been reduced. Allograft is reduced in volume quite a lot. This is the case to show that post-op 3 month prosthetic delivery and post-op 3 years, bone graft material has disappeared quite a lot. In the side view, you can see a lot of reduction of the bone graft material. Even though you put in a lot of material, not all of them turn into bone over time. During remodeling process, bone is resorbed, so you need to keep that in mind. Another case using allograft, bone is insufficient Sinus lift was performed. Inflammatory tissues were taken out. Using lateral approach, implants were placed. The volume of augmentation using only allograft is quite big. As time passed, it is reduced, further reduced at month 6. Post-op 3 years, number 16 implant. Bone is resorbed up to apex. Post-op 5 years, it has become more flattened. CT images of the patient. Post-op, the volume was quite large, but it was reduced over time. At post-op 3 years, a lot of reduction was observed. I prefer to use allograft, but when it is used in the sinus, a lot of volume reduction should be expected due to bone remodeling. Now, we can use xenograft instead of allograft. The characteristics of autogenous or allograft bone, the bone is replaced by new bone. So my bone is regenerated in these materials. When they are used in the sinus, the bone will be robust, but the downside is the material is reduced in volume. Xenograft, they are from cows, pigs, and even horses. So they are from animals. Bios, AOs are the examples of xenograft. As you know, xenograft, 100% of them are not resorbed over time. Not regeneration, but reparation occurs. Over a long period of time, the bone graft material remains and it is not readily resorbed. You need to keep in mind that new bone is formed surrounding graft materials when you use them. If you look at this paper, in many patients, the height reduction after 5 years, resorption by us was resorbed less than 10%, and the 10-year follow-up showed, according to biopsy, at 8 months, 29.8% was new bone and 70% bio-os. Post-op 2 years, 70% bone. Post-op 10 years, a lot of bone material remain. Xenograft over 10 years is not resorbed quite a lot in the sinus. The newly formed bone is surrounding the graft materials. Therefore, the graft material remain. So xenograft is not resorbed quite a lot. It is resorbed, but compared to autogenous bone, it is much less resorbed. So there are many different types of alloplasts. HA plus beta TCP is commonly used. HA and beta TCP are components of our body. Beta TCP is very fast resorbed. If it is made of only beta TCP, it is resorbed quite fast, but HA is not readily resorbed. Usually they are not used separately, but they are used in combination. Biphasic calcium phosphate is used a lot. Alloplasts are usually HA plus beta TCP, and their composition ratios differ from product to product. The ratios determine physical properties and the resorption rate. MBCP is a representative one. The ratio is 6:4 and it is not resorbed quite fast. Cerasorb and Cerasorb M are pure beta TCP, so they are resorbed very fast. Professor Okada's paper, long-term X-ray follow-up, 6 months after placement, 75.6% of beta TCP was resorbed. Over time, 2 mm is protruded, and 2.5 years after delivery, 0.7 mm protrusion due to resorption. So implant tip protruded beyond the maxillary sinus floor in 70%. Therefore, beta TCP is not used alone. If it is used alone, a lot of volume should be used. Alloplastic bone, QOS, has 25 to 75 ratio, so the bone is resorbed a little bit faster. Osteon bone material, the ratio was started with 7 to 3 and constantly changed to satisfy various needs for resorption rate. It's me, and this is my PhD dissertation paper using osteon over time. The ratio was 7 to 3. Even over a long period of time, it remains very stably. I looked at the long term 3 to 6 years. Over a long healing period, the bone material stably maintained the volume. It is slowly resorbed over a long period of time. They are affected by the amount of graft material. If it is large, more resorption. Long healing period, longer than 40 months, suddenly more resorption was observed. So this is what I studied. You need to consider this when you use alloplasts. If you use a lot of them, it will resorb more, but will remain stably. HA and beta TCP ratios determine the resorption rate. As you know, the FDBA among the allograft, if the bone is demineralized, it is too rapidly resorption. Short os is not demineralized, so I prefer this kind of bone. Xenogenic is not really resorbed, and alloplast varies by composition. I prefer to use allograft. When infection occurs, the bone is resorbed and it's visible on CT. So I like to use FDBA. That's my preference. Many people say xenograft is in contact with implants. They do not turn into my own bone. And is it okay in the long term? In terms of prognosis, I don't think we need to be concerned about that. My preference is allograft, but xenograft can be used for a long time with good results, according to reports. So this is, I believe, is individual preference. You need to remember xenograft is not resorbed fast and allograft is resorbed fast. Allograft and autogenous bone is resorbed quite fast, and considering that, we need to increase the volume or mix with other bone type. Therefore, for me, I use autogenous bone surrounding an implant and use allograft outside the implant, but this is my personal preference. Sandwich bone augmentation technique, I believe you have heard about it. Homlay Wang uses various graft materials not only for GBR but for sinus lift. Allogenic bone, where implant comes in contact with, and xenogenic bone over it to prevent resorption. Let's look at a case. Extraction in quadrant 2 and sinus lift using two materials. Lateral window detachment. AOS and short os were combined and put in, and the window was closed. Post-op, post-op 5 months and 5 years compared to allograft. This is irregular, but not much resorption is observed. So if you do not like the apex protruded like this, you can use the mixture with the xenograft or add xenograft. Long-term success. Long-term observation of maxillary sinus, autogenous bone graft 98%, bone substitute 95%, combination 95%. Regardless of the grafting materials used, we can have a pretty stable results in the maxillary sinus augmentation. Cortical bone, powder type, and syringe type, and allograft is my preference. How much do we need to use? The more, the better. One thing we need to consider is that bone materials are sold in different units. Allograft is available in cc, in volume. Xenograft and alloplasts are sold in grams. In general, if you multiply the xenograft gram times 2, it becomes the volume. 0.5 gram times 2 is 1 cc. Allograft is sold in cc, so we don't need to calculate. According to this paper, no bone grafting. Systemic review. According to Homley Wang, implant survival rate is similar, so we don't need to do bone graft. If the sinus is wide and if lateral approach is used, no bone graft would result in worse results. Without bone grafting, vertical bone can be gained by about 3 millimeters. That is, if residual bone is 8 to 9 millimeters, membrane is detached, and 10 millimeter implant is placed, it can be okay, but it means for residual bone of 5 millimeters or low with a lateral approach, bone graft material should be used. Allograft was used in this patient, but the apex of the implant protruded. I believe the purpose of performing sinus lift is to place an implant where bone is insufficient. To achieve it, I believe implants should be completely surrounded by bone. After bone remodeling, I believe the bone materials, if possible, need to surround the implant. If we do not use a lot of volume of the material, protrusion like this can happen. So we need to adjust the volume considering pneumatization. The papers here did a study on bias. Graft bone resorption in elevated sinus has a positive correlation with sinus width. If the width is wider, more resorption of graft material is reported. When sinus width is less than 12 millimeters, new bone is formed well. If it is more than 15 millimeters, the bone is not very well formed. Buccopalatal sinus width should be considered to adjust the volume of bone material, because if the width is too wide, the bone is not properly formed. Too much graft. What happens? 2 to 5 millimeters of graft material is recommended, and graft extrusion and complications can occur if you use too much graft. Limiting the height of the augmentation to less than 2.5 centimeters above the floor of the antrum is recommended. The height is usually 4 cm from the sinus floor. Ostium is located in the middle. Here, if graft material is put in too much over the ostium, graft materials will be extruded, pushed by mucosa. According to this paper, how much should we graft? How much resorption? Xenograft the least volume reduction, autogenous bone, the most resorption. At 6 months, graft resorption was reported. Autogenous graft resorbed the most, and alloplast and allograft similar, and xenograft is definitely less resorbed. So we need to refer to this kind of paper in choosing and adjusting the volume of graft material. If we use AOS, not much volume is required. And for example, if you use only shore os, you need to use more volume. Greater the augmentation, the lower the new bone formation. New bone formation is independent of preoperative residual bone height. So this needs to be considered as well. Myself, 5 millimeters and less than 10 millimeters. Therefore, 5 to 10 millimeters is what I prefer. According to papers, they cite numbers, but there's a big differences in sinus from person to person, so the numbers would not be significantly meaningful. For 10 millimeters lifting, 2 cc. If I use a lateral approach, I tend to use 1 cc or more. It's not totally dependent on the width. There are other factors involved. For example, shape of sinus floor, residual bone height, and number of implants. If the sinus is wide like this, more volume is required. In a narrow area, 1 cc can fill up to here, so there's a difference. If the residual ridge is very thin, simultaneously you will not be able to place an implant, and to place an implant you would require a lot of bone graft material like this. If a residual bone is 5 millimeters or 6, not much graft material would be required. You don't need to memorize the numbers, you can just make the decision yourself. Depending on the number of implants, the amount of graft materials would be different. Individual situations would be different, so you need to look at the situation and make a decision. Another important thing, we need to place the bone graft toward the sinus floor. Don't just push downward medial, mesial, and distal. You need to feel the farthest point from the window first. Feeling the palatal side is not easy, so you need to feel the area properly. Thank you for watching. For more details, you could come to my offline class. Thank you for listening.